Awesome. Thank you so much, Dr. Dingra, for that beautiful introduction. It's a pleasure to be with you all here tonight. As mentioned, my name is Dr. Katija Bonin, and today I'll be talking about the history and current use of opioids in chronic pain management. First, I want to acknowledge how challenging it is to live with and treat chronic pain. We often use the word manage because for many people, chronic pain cannot be completely cured. Instead, our goal is to help patients cope with their pain and improve their overall quality of life. While this can be difficult for healthcare providers, it is certainly much harder for our patients who experience this pain every day, people like many of you here tonight. Some of what I'll discuss may reflect experiences that you've had, and your perspectives are very important in understanding this topic. My goal today is to explain why opioids are used less often for chronic pain now than they were 20 years ago, and to discuss how and when they can still be very helpful. I know opioids can be a sensitive topic. There are many opinions about them and they become highly politicized. But here at Stanford, we are not pro-opioid or anti-opioid. We are pro-patient. And our focus is on finding the safest and most effective care for each individual. The goal of my talk today is to give you a clear overview of opioids and how they relate to chronic pain. Specifically, we'll review the history of opioids and how they've been used over time, as well as how opioids work in the body to relieve pain. We'll discuss the risks and side effects of opioids and go over evidence-based options for managing chronic pain, so you understand all the choices available. I will also cover the potential benefits of opioids, the common opioids used in chronic pain, and what safe prescribing looks like. By the end of this talk, my goal is for you to feel more informed and confident in discussing chronic pain treatment options with your healthcare team. Now, we're talking about this, and we've created this pain science lecture series because chronic pain affects about 1 in 4 adults in the US, as of the latest statistic in 2023. And 8.5% of these people have high-impact chronic pain, pain that frequently limits their life or work. Because so many people live with this kind of pain, treatments like opioids often come up in both public health and political discussions. Opioids are widely discussed because they can be helpful for some patients, but they also carry important risks, including dependence, side effects, and overdose. Policymakers and health experts continue to debate how to balance patient access to gain pain relief with the need to prevent misuse and addiction. Meanwhile, chronic pain remains one of the leading reasons that adults seek medical care, and many still struggle to find safe, long-term relief. That's why our goal tonight is empower you to make informed decisions, to lead to discussions, to understand what opioids can and cannot do. So when you work with your care team, you can choose what is best for your life. Now, this is a very abbreviated summary of the history of opioids, which we'll be exploring in more detail during this talk. Opioids have a long history, beginning in 1803, when morphine was first isolated from opium found in poppies. In 1989, almost 200 years later, a study then suggested that opioids could be safe for managing chronic pain, which led to the release of OxyContin in 1990. Between 1990 and 2000, opioid prescriptions increased rapidly as more doctors used them for pain relief. However, by 2011, the Center for Disease Control, called the CDC, declared an opioid overdose epidemic because overdose deaths were increasing dramatically. In response, the CDC and California published guidelines between about 2014 to 2016 aimed at reducing opioid prescriptions. Unfortunately, opioid-related deaths continued to rise still up until 2020. Most recently in 2023, though, new guidelines were released that shifted the focus towards individualized care, meaning treatment could be tailored to each patient to balance effective pain relief with safety. So to go into all of that in a little bit more detail, about 222 years ago, scientists found morphine in opium, which comes from poppy flowers. That was the start of using opioids as medicine. And I don't know if there's any other Wicked fans watching, but those who haven't seen, there's a famous scene in the musical Wicked where a magical spell is cast on poppies and it makes them to dance and causes most of the students to fall asleep. This shows how opioids make people feel sleepy and calm often. Now, later, scientists discover that actually our bodies make similar chemicals called endogenous opioids. These natural opioids, like endorphins, for example, also help to control pain, mood, and stress. When scientists found these natural opioids in the 1970s, it helped us to understand how opioid medicines naturally work, that they copy actually what our own body does to relieve pain. And we'll talk about more of this later. Now, for most of history, opioids like morphine were mostly used for short-term pain or pain at the end of life, such as after surgery or in cancer pain. In 1980s, a small study said that opioids could be safe for long-term pain that isn't caused by cancer. This study only had a few patients, but many people believed that it showed that these drugs were safe and that they worked well if you took them for a long time. Around that time, new opioids that lasted longer even were being made. And the big one was OxyContin. Drug companies started marketing these medications a lot, especially in the 1990s. They said that these new drugs could control pain for 12 hours, that addiction was very rare. And of course, doctors really wanted to help their patients and reduce the amount of suffering. They were told that these medications were safe and effective. For many doctors, it seemed like a very big step forward, finally something to help their patients. But the early information was not complete. We didn't yet understand that some people could build up a tolerance, the idea that you need more and more drug in order to feel an effect, or how quickly dependence could occur, which is the idea that you need the drug or otherwise you'll feel symptoms of withdrawal. By the mid 1990s and early 2000s, the number of opioid prescriptions had grown dramatically. OxyContin, for example, became a multi-million-dollar drug. Some pharmaceutical companies downplayed the risk of addiction and long-term safety. They promoted opioids as having no ceiling effect, meaning that you could just keep increasing the amount you took without any consequences. On the graph here, you can see that the year along the bottom, and notice that steep curve upwards that corresponds to the increasing prescribing of opioids. Over time, it became clear that higher doses were linked to more overdoses and death. When it became harder to get prescriptions, some patients turned to heroin or other street medications. And what began as a medical effort to help manage pain ended up as a major public health crisis. As opioid overdose deaths rose, public health agencies like the CDC and state organizations, including the California Medical Board, stepped in to try and protect their people. In 2011, the CDC officially declared what was happening an opioid overdose epidemic. California and CDC then released guidelines in about 2014 to 2016. These guidelines told doctors to keep opioid doses below a certain level, called 90 morphine milligram equivalents, and to slowly decrease or taper doses whenever possible. The main goal, of course, was safety. Fewer patients and people would overdose if doctors prescribed opioids more carefully. But many people misunderstood the guidelines. Instead of seeing them as suggestions, some hospitals, clinics, and insurance companies treated them as hard, fixed rules. This meant that patients who had been taking opioids for years, even if they were managing their pain and living well, were sometimes forced to cut their doses quickly or stop completely. Around the same time, California started the Death Certificate Project, which would look into suspicious doctors whose patients had died while taking opioids. This, of course, made many doctors feel afraid to prescribe opioids at all, even for patients who really needed them to live normally. The result was that the system swung way too far in the opposite direction. Instead of too many opioids being prescribed, now some patients with chronic pain were left without enough medicine to control their pain. This caused immense suffering for many patients and highlighted just how tricky it is to balance safety with pain relief. It also showed doctors why focusing on individualized care, meaning each patient's treatment is adjusted to fit their needs, risks, and goals. Even as doctors started prescribing fewer opioids, overdose deaths didn't go down, though. In fact, they went up. Many people who had become dependent on opioid prescriptions turned to heroin or street opioids when they could no longer get their prescriptions. Around the same time, fentanyl entered the illegal drug supply. Now, fentanyl is actually a super common medication that we use all the time in medicine, especially in the operating room or during pain procedures. It's the sedation medication that we use to keep people safe and comfortable. When it's given by a doctor who is monitoring you and it's made in a pharmacy, it's very safe. The problem is illegal fentanyl. It can be much more concentrated than opioids like morphine or OxyContin. And when it's made illegal, you don't know how much you are getting. A big problem is that street oxycodone was made to look nearly identical to medical grade, and it was mixed with fentanyl, making it even more addictive and extremely dangerous because it would give someone too much opioid that caused sedation and could kill them. I think it's important to make clear that the rising overdose deaths was not only caused by changes in prescribing, but also by illegal drug markets, greater demand for opioids, and worsening economic and social conditions for some populations. During the COVID pandemic, overdoses climbed even faster due to social isolation, mental health struggles, job losses, and reduced access to treatment. All of this shows how complex the opioid crisis is and why it remains a serious public health concern today. Today, we are learning from both sides of the pendulum. From a time when opioids were prescribed too often to a time when they were prescribed too little. The newest CDC and California Medical Board guideline in 2023 now focuses on individualized care, meaning treatment plans that are made to fit each person's unique needs rather than following a one-size-fits-all rules. For some people, opioids can still play a role in managing their pain, especially when they're used carefully and combined with other treatments like physical therapy, counseling, and non-opioid medications. For others, opioids may not help much in the long run and could cause more harm than good. The main goal now is to improve your function and quality of life, not just to lower your pain score. As your care team, our goal is to work with you, not against you, to find the safest, most effective plan for your situation. You deserve to be heard, supported, and treated with compassion. Pain is very real, and managing it takes teamwork and trust. We cannot change the past, but we can learn from it to provide safer, more balanced care for everyone moving forward. Now, there is a lot of information and sometimes misinformation or embellishment about opioids in the media. Movies and shows often focus on the dramatic or cinematic side of opioid use, addiction, crime, tragedy, because that makes for powerful stories. While this can help people understand how serious the opioid crisis is, it doesn't show the full picture. For example, Dope Sick shows how drug companies helped start the crisis by promoting opioids as safe when they were not. The Brutalist takes a look at how pain and addiction can change a person's life. And Four Good Days shows the emotional struggles of addiction and recovery. These stories are very important, but we also have to remember that in real life, opioids can be used safely and helpfully. In hospitals and operating rooms, opioids are used every day to help control pain after surgery. Many people with chronic pain also use opioids carefully, under a doctor's supervision, to help them live more comfortably and function better. Hollywood doesn't often show this safe medical side, but it's a very important part of the story too. Now, we've covered a lot of information and emotional history. Before we jump into the science and medical side of things, like how opioids actually work, the different types and their side effects, let's just take a moment if you need to stand up, move around, and stretch just like this cute little kitty cat. All right. Now, as I mentioned earlier, opioids actually started from nature. They came from the sap of a poppy flower. The first major opioid medicine discovered was morphine. And again, this was early in the 1800s. Morphine was actually named after the Greek god Morpheus, who is the god of dreams. From that point, scientists developed many other opioids. Some still directly or partly coming from the plant, and these are called natural or semi-synthetic opioids. Now, natural ones include morphine and codeine, while semi-synthetic ones are like hydrocodone or oxycodone, because they're just a little bit modified version of the plant compounds. On the other hand, synthetic opioids are made entirely in a laboratory with no poppy ingredients at all. Examples include fentanyl, methadone, and tramadol. The difference between synthetic and non-synthetic opioids isn't about being good or bad. It's about how the drug is made, how fast it works, how long it lasts, how strong it is. Synthetic opioids can be designed to be made to work more quickly, last longer or shorter, and be more or less powerful. For example, fentanyl is very strong and thus it can be used in tiny, precise doses for surgery and severe pain. Now, you might wonder, why are there so many different types of opioids? And the main reason is that not all people's pain is the same. Some people need fast relief, like after surgery, while others need long-term pain relief that requires steady control throughout the day. Different opioids let doctors match the medicine to the type of pain and how long it lasts. This can also vary in potency, which is how strong they are compared to morphine. Codeine is a lot weaker, while drugs like hydromorphone and fentanyl are a lot stronger. A stronger opioid doesn't mean that it's better. It just means that you need less of the medication in order to get the same pain relief effect. When doctors compare opioids, we always use morphine as the standard, almost like how we use the US dollar to compare money from other countries. This system is called the morphine milligram equivalence, or MME. It helps doctors understand how strong one opioid is compared to another. For example, if morphine is like $1, then codeine might be worth about 15 cents because it's weaker, while buprenorphine or Butrans would be like $12 because it's much stronger. This comparison helps doctors safely adjust doses, switch between opioids if needed, and make sure that patients gets the right amount, not too little and not too much. For patients, the important thing to know is that potency doesn't mean danger. It just means that you have to be careful to match the right value of medicine to your pain needs. Now, opioids work by attaching to special proteins in the body called opioid receptors, which are found in the brain, the spinal cord, and other parts of the body. When an opioid attaches or binds to its receptor in the brain and spinal cord, it helps to reduce how much pain that you feel. The more receptors that are activated, the more pain relief you experience. But it also means the more side effects that are likely to occur, like sleepiness or constipation. Two ideas to explain how well an opioid can work once it reaches its receptor are the ideas of affinity and intrinsic activity. To explain this, affinity is like how well a plant fits into your garden. A plant with high affinity is naturally suited to the garden's soil, sunlight, and weather, and it will naturally grow easily with little help. It gets stuck there and stays there for a long time. Similarly, it makes it harder for other molecules or plants to push it off. On the other hand, a opioid with low affinity is like trying to grow a tropical plant in a cold, dry garden. It doesn't fit well, won't stay attached for long without extra effort. Intrinsic activity is the plant's own energy or drive to grow. Some plants have natural strong vitality and they can produce fruit even in modest conditions. This is like an opioid that strongly activates its receptor to turn down pain signals. Now, others have a lot weaker growth, meaning that they don't trigger as much change, like an opioid that binds but doesn't provide a lot of pain relief effectively. Once opioids have done their job, your body metabolizes it or breaks them down, mainly in the liver. The broken down parts are then cleared through your urine. Different opioids are processed at different speeds. Some start working quickly but wear off fast, while others last longer in the body. That's why your doctor chooses certain opioids or doses very carefully to match how your body processes the medication to balance pain relief with safety. Now, opioids work on different receptors throughout the body to relieve pain, but because they act in multiple areas, they can also cause short-term side effects. One of the most common side effects patients experience is constipation because opioids slow the movement of the intestines. This is why patients may be advised to take stool softeners or drink plenty of water when starting an opioid medication. Another frequent effect is nausea and vomiting, which is something that people often experience after surgery or anesthesia. This happens because opioids slow the digestive system and you have more particulate matter that is stuck there, but also because it can trigger the vomiting center in our brain, which is why often anti-nausea medications are given after surgery and alongside opioid medications. Now, you probably heard that opioids can also cause sleepiness or sedation, which can make you feel drowsy and less alert. In higher doses, even, they can slow your breathing, which is why doctors must carefully monitor, especially after surgery or in patients who are more sensitive or are on multiple sedating medications. Some patients may even experience euphoria or have hallucinations, which is the high effect that people sometimes hear about in the media. While these effects can be noticeable, for most patients, they are usually mild and manageable with medical supervision. The key takeaway is that short-term side effects are normal and expected when you're using opioids, and doctors know how to minimize them so that pain relief can be safe and effective. When opioids are used for a longer period of time, the body can actually start to adapt to them. One of the first changes that can happen is called tolerance. This means that over time, the same amount of medication won't work as well as it did at the beginning. The body develops tolerance naturally after repeated use, and higher doses of opioids may be needed to maintain the same level of pain relief or analgesia. Tolerance can build up even after the first few doses, but it usually takes a number of weeks of regular use to become noticeable. Tolerance develops quickly to some effects of opioids, such as sleepiness, slowed breathing, pain relief, and the stomach upset. However, there's actually very little or no tolerance to the constipation that can happen and the small pupils that it can sometimes produce, which means that those effects continue even after long-term use. Sometimes patients might notice that the pain relief doesn't last as long or that it takes longer for the medication to start working. This doesn't mean that the medication has stopped working. It means your body's receptors have adjusted. Depending on the medicine and the person, doctors might respond by changing your dose, taking a short break, or switching entirely to a different opioid to help keep pain under control safely. Another completely normal body change is physical dependence. This does not mean addiction. It just means that your body has gotten used to having the medication around. Almost like if you drink coffee every morning and then you stop drinking it, your body really notices. If opioids are suddenly stopped, though, you can feel significant withdrawal symptoms like sweating, irritability, muscle aches, or even more sensitivity to pain, often described as flu-like symptoms. These symptoms can be uncomfortable. They're not dangerous, but they can be managed to be more tolerable. Doctors prevent this by slowly lowering the dose, called a taper, so the body has time to adjust and regulate. Now, addiction is something very different. Addiction involves strong cravings, loss of control, and continued use despite harm. Most patients who are prescribed opioids for pain do not become addicted, but doctors still monitor very closely to prevent it because it can be a very devastating side effect. Over time, opioids can also affect our hormone levels, like lowering testosterone. And in some people, it can even cause rare problems called opioid-induced hyperalgesia, which is a big word to say that it actually becomes counterintuitive and it makes the body more sensitive to pain. The key message is that these long-term changes can happen, but they also can be managed safely with regular check-ins, careful dosing, and a good treatment plan. When used responsibly and with guidance, opioids can still be an important tool for managing chronic pain while keeping you safe and comfortable. Now that we've talked about opioid medications, I want to come back to the idea that your body makes its own opioids called endogenous opioids. These are natural chemicals and they work on the same receptors in our bodies as opioid medicines. Our body uses them all the time to help manage pain and keep things in balance. For example, after surgeries like dental work or abdominal surgery, studies show that the level of endogenous opioids in your body naturally rises to help you by yourself reduce your pain. Endogenous opioids don't just help with pain, they also protect our body in other ways. They can help brain cells stay healthy, reduce damage from stress, and keep nerve signals working properly. They can even help the heart and give a feeling of well-being or happiness, which is part of why things like exercise or spending time with friends feel so good. Like opioid medicines, these natural opioids can sometimes cause sleepiness or slow digestion, but really only in very small, safe, and often unnoticeable amounts. Even some treatments like acupuncture may work by triggering the release of these natural opioids. The main idea is that our bodies have a built-in opioid system that helps control our pain and protect organs. Understanding how it works helps doctors find safer and more effective ways to help patients feel better. Another really interesting part of pain research is something called the placebo effect. What it is that someone can feel less pain when they think that they are getting a medical treatment, even if they aren't getting a real one. Scientists have found that this happens because the body releases its own natural opioids, the same chemicals our bodies make to fight pain. Brain scans show that during a placebo response, certain areas of the brain that control pain become more active. If a medication called naloxone, which blocks opioids, is given, the pain relief that you're experiencing goes away, showing us that the body's natural opioid system is helping you. Exactly how placebo works is not fully understood, but it does involve complex reactions in the brain. This includes increases in feel-good chemicals like the endorphins, like the endogenous opioids, and dopamine. When activated, there's greater activity in the brain linked to areas of mood, emotions, and self-awareness. All of this can actually help reduce pain and make people feel better. You can think of placebo effect as your brain telling your body what it needs to feel better, even without medicine. The research shows that in the mind and the body are closely connected and that our natural opioid system plays a big role in controlling pain. Now, you don't need to take a pill to take advantage of this placebo effect in your everyday life. Though a pill doesn't hurt, your body can help itself feel better in real ways. One of the keys is in healthy rituals. Eating well, exercising, meditating, doing yoga, or spending time with family and friends can all send signals to your brain that your body is ready to feel better. Another important piece is expectation. Believing that your actions will help can trigger your body's natural opioids and other feel-good chemicals like dopamine. And doing these habits consistently makes the effect stronger because your brain starts to recognize the ritual as a sign to help your body heal. Scientists think that the combination of healthy habits, positive expectation, and social connection is what helps to make the placebo effect real, giving you benefits without any of the side effects the medications sometimes have. So, by practicing some of these simple habits, you're tapping into the natural system that doctors study to help reduce pain and stress. Now, let's talk a bit about how we define pain in chronic pain. Many of you probably already know what pain feels like, much better than I can describe from a textbook. Pain isn't just a physical way of feeling, it's also emotional. Usually, it's your body's way of warning you that something is wrong, like an injury or a medical condition. Treating the underlying problem often helps the pain to go away, but sometimes pain sticks around, even after the original problem is treated or the condition can't be fully fixed. When pain lasts for more than 3 months, we call it chronic pain. For some people, chronic pain becomes the main health problem that they face, and it needs its own evaluation and treatment. As we talked about, chronic pain is very common and it's very complex because it's not just about your body. Your mind, your emotions, and your social life all shape how pain is felt and managed. Recognizing this complexity is the first step towards finding some relief. Some people ask, why do some people develop chronic pain? The truth is, we do not have the answers yet. We know it is very complicated and it can't be just narrowed down to an injury or a disease. It's a combination of biological factors like nerve changes or inflammation, emotional factors like anxiety or stress, and social factors like work, family, and support systems. Understanding that chronic pain is complex helps us to approach it with patience, compassion, and realistic expectations. When we talk about treating chronic pain, doctors often think of what we call the 4 Ps of comprehensive care: physical therapy, psychology, procedures, and pharmaceuticals. You can think of them like 4 legs of a chair. Every leg is important to keep the chair stable, and that is the chair that you are sitting on. It's your quality of life. Sometimes even a 5th leg is added for complementary strategies like massage, chiropractic care, acupuncture, yoga, tai chi, aquatic therapy, nutrition, or sleep optimization. Physical therapy is one of the strongest legs. You might have heard the saying, motion is lotion. Moving your body safely can help improve your mobility, strength, and overall function. It can also help to break patterns of fear avoidance, where people stop moving because they're afraid it will hurt. And this can actually make your pain worse over time. Psychological approaches are another extremely important leg on our chair. When we feel anxious, stressed, or sad, our brains can actually amplify our pain and make it louder. Pain psychologists help patients calm the mind, manage emotions, and strengthen the natural power of your brain to reduce pain. They work almost like our body's own endogenous opioids, helping us to cope more effectively. Every patient is different. Some chairs might need 2 or 3 legs or even extra legs, and not every approach fits everyone. The goal is to build a chair that supports you safely and comfortably, using the combination of strategies that works best for your body and mind. Now that we've talked about the legs of the chair, let's zoom in on medications, which are one of those legs. Opioids and non-opioid medications work in different parts of the body. And when we use them together, something special usually happens. They can actually help each other work better. We call this synergy. Think of it like two teammates helping each other to score a goal. Together, they could do much more than they could alone. Many of the non-opioid medicines that we use are considered anti-seizure or antidepressant medications. This is because they calm overacting nerves in the spinal cord, the brain, and elsewhere, which is exactly where our pain gets transmitted and processed. When we combine these types of medications with opioids, patients often get better pain relief and sometimes need lower doses of opioids, which can mean fewer side effects like sleepiness, nausea, or constipation. Of course, doctors always need to make sure that that combination is safe, checking for interactions and adjusting doses as needed. This is a great example of how different medicines can work together and be part of a bigger plan to help manage chronic pain safely and effectively. Now, when deciding if opioids are the right choice for someone with chronic pain, doctors and patients work together. Before starting, the doctor and patient will set clear goals. For example, I want to improve my sleep or walk farther, or I want to do daily activities and have a less focus of pain in my mind. Doctors also do a risk assessment by learning about the patient's medical history and any other medications they take and whether they've had problem with substance abuse or addiction in the past. Opioids are then usually trialed on a trial basis, meaning they're used for a short time to see if they can help. Once treatment begins, it's very important to monitor always for both benefits and harms. That means checking if the medication is really helping and watching closely for side effects, like sleepiness or mood changes. If the risks ever start to outweigh the benefits, we can always change the plan and stop opioids safely. One common medication used for chronic pain is the Butrans patch, which contains buprenorphine. This patch is placed on your skin and changed every 7 days. It slowly releases the medication into your blood, giving steady pain relief all week. The Butrans patch is a great option because it's very safe. There is a low risk of opioid use disorder, sleepiness, or overdose. Buprenorphine works by sticking very tightly to those opioid receptors, but it only turns them on part way, almost like dimming up a light instead of fully turning it on. This means it can help pain while lowering the chances of harmful side effects. Other common pain medicines that we prescribe of opioids are oxycodone and hydrocodone. These drugs are well tolerated, they're easy to find in most pharmacies, and they start working about 30 minutes and last about 3 to 6 hours. They can bring pain down quickly, but the effect doesn't last that long, so they usually need to be taken several times a day. When you hear names like Percocet or Norco, it means that the opioid has been combined in Tylenol, almost like a 2-for-1. And the reason that they do this is, like we were talking about earlier, it creates a stronger synergistic effect, like the two soccer players working together to help get better pain relief, and it offers a nice, convenient packaging. As we've reviewed, opioids can have side effects that affect your mood and perception, and the history of unsafe prescribing in the past has made doctors more cautious about how we use them today. We're now in a new era of opioid prescribing, one that focuses on safety, communication, and shared expectations. To support this, we often use a treatment agreement, which is simply a written plan that helps both the patient and provider stay on the same page. This agreement usually says that you will get your opioid prescriptions from only one prescriber. Take your medication exactly as instructed and attend regular follow-up appointments. It also includes urine testing, not as a punishment, but as a safety tool to confirm that your prescribed medication is in your system and there's no unexpected or unsafe drugs that could harm you that are present. This protects both you and your healthcare team by identifying any risks early. At Stanford, because we are a specialty comprehensive clinic, our goal is to help patients, as many as we can, achieve stability and then transition care back to their family doctors, while still providing procedures and repeat consultations as needed. For this reason, when starting somebody on opioids, we first touch base with your family doctor to ensure that they'll be comfortable continuing the prescriptions that we stabilize you on. This ensures that you have safe, continuous, coordinated care throughout your treatment. In addition, your doctor will check a statewide California pharmacy tracking system, which records all prescriptions for controlled medications in California. We must review the system at least twice a year to make sure that the medication plan that you're receiving is safe and that no duplicate prescriptions are being filled from other sources. Together, all of these steps, treatment agreements, coordination with your primary care doctor, urine testing, and pharmacy monitoring, create a safe and transparent plan that builds trust and reduces risk, and helps to ensure that the benefits of opioids continue to outweigh the potential harms. Now, sometimes opioids can stop working as well over time, or they can start causing more side effects than benefits. In these cases, your provider may recommend slowly reducing or tapering your dose. The goal of tapering is never to punish or to cut you off medication, but to keep you safe and let your body's natural opioids reset. Coming off opioids too quickly can cause an awful withdrawal symptoms that we reviewed earlier. So to avoid this, we go slowly, sometimes decreasing the dose over weeks or even months, and provide support through the process. A slow taper allows your body's receptors to adjust gradually, minimizing discomfort. In some cases, your doctors might suggest a short opioid holiday where you come off the medication for a few weeks to a month to reset your tolerance. This can make your opioids more effective again at a lower dose when you restart them. The benefits of tapering include improved mood, energy, and alertness, while reducing the risks like constipation, falls, and dependence. The key to tapering is always collaborative, individualized, and supported, never rushed. As doctors and scientists keep looking for safer ways to treat pain, some new exciting medications have been developed. One of the newest is called Jornvax or suzetrigine. It's a non-opioid pain medicine, which means it works very differently from traditional opioids. Instead of acting in the brain and the spinal cord like opioids do, Jornvax works out in our sensory nerves, the nerves in your body that first sense pain and send those messages to your brain. Jornvax blocks something called a sodium channel, which is like a tiny gate on the surface of a nerve cell. These gates open and it close to let electrical signals travel along the nerves. Jornvax blocks a specific gate called NaV1.8, which is interesting because it's only found on pain-sensing nerves in the body. By keeping this gate closed, Jornvax can help stop pain messages before they even reach the brain. And because it works on only those nerves, it helps stay away from the heart and brain where many undesirable side effects can happen. In a study published in 2023, people who took the highest dose of Jornvax felt a little more pain relief compared to those who took a placebo or a sugar pill like we were talking about. The effect was mild, and it hasn't been compared directly to opioids, but it is still very exciting. This is the first new kind of pain medicine that we've had in decades. And it gives hope that we can treat pain in safer, non-addictive ways by targeting the pain signals where they start. Opioids can play an important role in managing pain for some people. They can provide real relief and improve quality of life, but they do come with risks, including side effects, dependence, and the potential for misuse. That's why doctors today use them more carefully than we did in the past, as part of a bigger, safer plan. We now know that the best results come from multimodal care, using several tools together rather than relying on just one. Think of your pain like a sturdy chair. The more legs it has, the more sturdier it feels. Physical therapy, psychology, medications, procedures, and alternative therapies all strengthen that chair that supports you. You deserve compassionate, personalized care that fits your life and goals. My goal today was to help explain why opioids are used less often for chronic pain than they were 20 years ago, and to show that they can still be helpful when used thoughtfully and safely. I know that opioids can sometimes be a sensitive and emotional topic. There are many opinions about them, and the issue has become highly politicized. But here at Stanford, we are not pro-opioid or anti-opioid. We are pro-patient. Our focus is always on finding the safest, most effective, and most compassionate care for each patient we treat. Managing chronic pain is complex, but with honesty, teamwork, and a balanced approach, it's possible to find relief and live well. Here are some additional classes and group resources that I think we'll be posting in the chat. And a little humor to finish us off from one of my favorite comic strips, The Awkward Yeti. I want to thank everyone so much for coming, for listening. We will now move on to some of the questions that you have.